Hello again. Today I'm going to review the September cases that we talked about. My apologies that it's now October and I'm a little bit late getting this out. The first case that we talked about was a 75-year-old female with COPD. We watched a video from YouTube about COPD versus emphysema. Emphysema and chronic bronchitis are both pieces of COPD. Generally speaking, I would say most patients in practice probably don't necessarily know the distinction of which one they have. Some patients don't know that COPD and emphysema are the same. You'll ask them about any lung problems, they'll say one, and you ask them about the other, and they'll say no, they don't have it, but there's a lot of overlap there. So the priorities for patients who are really, really sick with COPD is CPAP and nebulizers, continuous nebulizers. Solumedrol and magnesium are also both options, but they're sort of down the road. Typically, we don't see like a huge improvement with those things, like in the immediate time frame, but they're helpful. So sort of along the same lines as asthma, you can do solumedrol and magnesium for those as well, but the big things are nebs and CPAP. So, and like we talked about, like we have talked about a few times about CHF and COPD, patients often have both, and ultrasound is a great way to look at B lines to know if you're on the path of severe CHF. You're going to have lots of B lines, and if you have COPD, you're not going to have any B lines, or maybe just a couple, probably none. But it should be pretty obvious if you have a lot of B lines that CHF is your problem that you're dealing with. And again, the priority there is going to be CPAP. So another patient we have was a 76-year-old female who took a fall walking around at the mall. Some good things done in this case is that they changed the destination based on how the patient was doing. And they just didn't look, it looked like more severe trauma the way the patient was acting. So they chose to go to a trauma center instead, which I think was a good decision. Can Southdale Methodist probably handle head trauma, like isolated head trauma? Probably yes. But I wouldn't fault you for going to a trauma center for those patients. C-spine precautions are important in old people, even if they don't complain of neck pain, because often they have fractures and they just don't seem to have as much pain with that. I've seen that plenty of times. A couple of things about the head wounds. This one wasn't bleeding very much, but just a caution that if you do have a patient with a big head wound that bleeds a lot, I've seen patients roll into the ER with a big, huge like wrap on, like it's a turban, and they haven't actually stopped the bleeding. So by the time you get all the dressings off, you just have lots of abdominal pads soaked with blood, and you haven't actually stopped the bleeding. Usually it takes very focal pressure if you have a really bad bleeder, and just a big huge wrap isn't going to do it, and it also hides the blood loss, so that's not so good. So make sure if you're going to wrap somebody's head, make sure that you've actually stopped the bleeding first before you just hide it under a bunch of dressings. One other comment I would say about just sort of engaging how bad head trauma is, scrapes versus like focal stellate lacerations, I kind of put in two different categories, like because the vector of forces is different. So if I trip when I'm walking and I just have scrapes that go like this, the chance of having a severe head bleed I would say are less. Again, this is just anecdotal, it's not studied, but if I fall and hit my head and I have a huge hematoma right here and a stellate laceration that like where the skin just exploded, that's a lot more force going through my head than if the force is transmitted scraping down my face. So just something to keep in mind. One other comment about patients when you don't really have any history, and I'll talk about this case and then the next case as well, but being on blood thinners, when you're elderly people on blood thinners are almost always, it's almost always for AFib. Let me take that back. Maybe not almost always, but a large proportion of the time when older people are on blood thinners, it's for AFib. There are other reasons, obviously heart attacks, strokes, other things, but AFib is so common in elderly people. You can sort of gauge their history. If you don't know maybe the history, or the patient doesn't know the history, but they say, yes, I'm on blood thinners, or if you find that the patient has AFib, you can probably interpret that they probably are on blood thinners. So, okay, and then we had an 80-year-old female with tachycardia. The question was whether it was AFib or SVT. There was discussion about adenosine and whether we need to give that or not. And the patient was okay, so we're not forced to act. So I think that's fine. And again, this patient, I remember there was some history, and I don't remember exactly what, but either we knew the blood thinners or we knew the AFib or both. But one can kind of be a surrogate for the other, if you will. The patient was also DNR, DNI. The key point about that is to remember that only applies when the patient's dead. So we do everything else that we would normally do for those patients. Again, when you get into more advanced stuff at the hospital, maybe you want to back off on what you're doing because of the risk of causing something worse to happen. But generally speaking, the best thing to keep in mind about DNR, DNI orders is that only applies when the patient's dead. Otherwise, we do everything else that we would normally do for patients. So the last patient that we have was a peds choking case. The kid choked on a foreign body. We watched the bourgeonnage video, and I believe the final diagnosis was the kid had a coin in the esophagus, just like on the video. And again, kudos to the crew in Quattro for taking the patient to a change in the destination. Because the kid didn't look well. So, and again, if you remember this case, the vitals looked pretty good, but something about the kid, he just didn't look well. So they used that and then just go off the vitals, which would have been a mistake. So, and it turned out the kid had a good outcome. So anyways, those are the September cases. Have a good day and enjoy this fall.